Good day, everyone. I'm Mark Rothenberg, the president of the International Eosinophil Society, and it's a pleasure to have you here today for this June webinar focused on eosinophilic granulomatosis with polyangiitis, EGPA. Next slide, please. We're pleased to have this webinar simultaneously translated into Japanese. For those interested in this single translation, please refer to the instructions on this slide, which is primarily going into the bottom right-hand corner of your Zoom screen, searching for interpretation and clicking on Japanese. If it's not directly in the interpretation link, you may need to go into the more icon. If you have any questions, feel free to send it through the chat. A little background about our society. The International Society, also known as IES, is an organization of scientists and clinicians interested in the eosinophil, a blood cell strongly associated with many diseases. The Society sponsors biennial meetings, monthly webinars, and other educational programs for its over than 300 members. We review new information about the eosinophil and its role in health and disease. Those who are interested in becoming a member or being part of our society, including just becoming a member on the mailing list, please scan this QR code or visit our website address as shown. We're soon pleased to announce that we'll be having a joint membership drive with the European Mast Cell and Basophil Research Network. More information about that will be forthcoming. Also wanted to point out that we're currently offering free membership for early career individuals. Refer you to this QR code with more information. Next slide. We're also pleased to have a new program, which is reviewing what we consider to be seminal articles in the field. These are posted on our website, and they are selected, reviewed, and scientific and clinical correlations, and sometimes critique, but most of the time laudatory comments are provided about the articles. Refer you also to the website in this QR code. Next slide. Wanted you to save the date for our next biennial meeting, the 13th Congress of the International Eosinophil Society. We're pleased to have that in Montpellier, France, on July 7th to 11th in 2025. The program will soon be announced. We have a very strong lineup of speakers, and looking forward to having a really exciting meeting with a lot of new information being revealed. Please save the dates now. Next slide. The next webinar will be in August, and it'll be a joint webinar with our colleagues in India, who are part of the Indian Society of Hematology and Blood Transfusion, and the Postgraduate Institute of Medical Education and Research. We are looking forward to this little lengthened webinar, which will be on August 7th. Time is convenient, hopefully, for the Indians. We've planned this out with them, and we have a very strong lineup of speakers. Looking forward to this meeting, and encourage you to register now. I want to thank our supporters, particularly for the webinar today, AstraZeneca, and our corporate advisory councils, which includes the platinum member AstraZeneca, gold members Allakos, Amgen, GSK, Sanofi, and Regeneron, and bronze members Aritea Therapeutics, Bristol Myers Squibb, Celldex, and Takeda. The moderators today is Professor Praveen Akuthota at UCSD, San Diego, as well as a young investigator, Matthieu Groh from France. We're very pleased to have them moderating, and I'm going to turn this over to them. Praveen.
Thank you, Mark. Hello, everybody.
And hi, everybody.
Thanks for joining this IES webinar. Before we start, just a few technical considerations that Mark has already mentioned. So as usual, questions are very welcome, and To do so, you can use the Q&A button anytime during the presentations, and we will read the questions after the experts have made their lectures, but there will be no place for Q&A in between lectures. Also, please note that all attendees are muted during this webinar and that the chat feature is disabled. This webinar is being recorded and ultimately will be posted on the IES website, both in English and Japanese. And last, as Marcus mentioned, you can view closed captioning or live transcription during the webinar by clicking on the Show Captions button, which is on the bottom part of your Zoom. So important for Japanese attendees, you can also access simultaneous translation by clicking on the interpretation icon on the Zoom menu. Next slide, please. And so today we have a very exciting program and a wonderful lineup of speakers with 3 international experts in the field of asthma and more specifically EGPA. So first, my co-chair Praveen Akuthota will give an introductory lecture on the clinical overview of EGPA. And then Professor Michael Wechsler from National Jewish Health in Denver, Colorado will drive us through the impact of eosinophil depletion in EGPA. And last, Professor David Jackson from Guy's Hospital and King's College in the UK will show us the multidisciplinary approach of EGPA and some of the future directions. So without any further ado, it's a pleasure to introduce my co-chair and first speaker, Praveen Akuthota. So Dr. Akuthota is a professor of clinical medicine at the University of California, San Diego. He is the principal investigator for the San Diego Clinical Center in the NHLBI PRECISE network that is studying precision interventions in severe asthma. His research group is involved in multiple multi-center studies in eosinophilic disease and asthma. So thank you, Praveen, and the floor is yours.
Thanks, Matthieu. I really appreciate the very kind introduction, and I'm going to share my screen to start. And as I'm doing that, would also like to thank the IES and AstraZeneca for the sponsorship. Really, it's a pleasure to participate in the IES program. IES has been very meaningful to my career. So yeah, thank you everybody for being here. So as Matthieu said, I'll be speaking about a clinical overview of EGPA. You'll get more clinical details about EGPA from Professor Wechsler, and then some new horizons from Professor Jackson. These are my disclosures with a few companies and education entities in the US. So, as many of you know, EGPA is also or formerly known as the Churg-Strauss syndrome, and that comes from the original description of EGPA from Churg and Strauss that was published in the American Journal of Pathology in 1951. So you can actually get this paper online through your university library if they subscribe. It's an interesting read. And Churg and Strauss, who are pathologists at Mount Sinai in New York, they described a case series, an autopsy case series, critically, of patients who died and had a syndrome of severe escalating asthma and rhinosinusitis, along with hyper-eosinophilia. And then on microscopic specimens, they had pneumonia, not in the infectious sense, but in the infiltrative sense, and eosinophilic pneumonia. And then critically, in these patients who passed away from their disease, they had eosinophilic arteritis and granulomas, so they had vasculitis. And so that's the original conception of EGPA from Churg and Strauss, which again, I'll emphasize is based on disease coming to its end stage and resulting in the death of the patient. And actually, I'm going to pause for a second and tempt the fates and see if I can get a laser pointer here to work on my screen. There we go. Hopefully that is visible to everybody. From an epidemiologic perspective, EGPA is considered a rare disease. In the title here on this slide, I'll editorialize a little bit. It is rare, but it's potentially underestimated. I think because it's difficult to diagnose, there's under-recognition of the disease, et cetera. But as far as a meta-analysis or a paper that brings together some of the estimates out there of the prevalence for EGPA, I think this is probably the best paper that's out there from a few years ago from GSK actually. And if you look on a country level, you'll see prevalence of EGPA that is anywhere from 5 to about 20 cases per million. And then in their overall meta-analysis for that I'll blow up here for Europe, the prevalence that they come up with is about 12 cases per million, and globally about 15 cases per million. Interestingly, this same group just last month published a paper in ERJ Open Research that suggests, at least in the United Kingdom, that the prevalence of EGPA has gone up over time. That may be due to increasing recognition and improved diagnosis just from improved recognition. But in that paper, they demonstrated that the prevalence of EGPA may be as high as 40 cases, around 40 cases per million now, compared to a decade or two ago. From an overall clinical perspective, the EGPA is a potentially multi-organ systemic eosinophilic disease, where on one pole of disease, you have a condition that's very much a severe asthma variant, characterized by asthma and pulmonary infiltrates. And on the other end of the spectrum, this is a little bit of an artificial distinction, calling it two spectrums of disease, a disease that has systemic manifestations very much consistent with other systemic autoimmune vasculitides like glomerulonephritis. And some of these disease manifestations do tend to group, but not completely correlate with ANCA negativity versus ANCA positivity. And many of you have seen this slide over and over again in talks about EGPA, but EGPA was renamed from the Churg-Strauss syndrome and the Chapel Hill Consensus Conference in the rheumatology community over 10 years ago now, and grouped in with the other ANCA-associated small vessel vasculitides, microscopic polyangiitis and granulomatosis with polyangiitis, formerly Wegener's, and again renamed as eosinophilic granulomatosis with polyangiitis from its former eponym of the Churg-Strauss syndrome. And I think this grouping is fair. EGPA can be an ANCA-associated small vessel vasculitis, but I think in some ways it's also maybe does this disease a disservice as far as diagnosis, because it implies that EGPA must always be an ANCA-associated small vessel vasculitis. But it's really only at the end of disease, like those autopsy specimens that Churg and Strauss found in the 1950s, that you definitively see small vessel vasculitis. And we know that the systemic vasculitis can be modulated by the presence of systemic therapies like repeated courses of oral corticosteroids. So, and even in the name itself, eosinophilic granulomatosis with polyangiitis, that implies a pathologic diagnosis, when really, as I'm sure Professor Wechsler will get into, EGPA is best considered as a syndromic diagnosis in most cases, where pathology can be helpful but is not absolutely necessary. So to that point, you know, what you think of as EGPA, or what group of diseases EGPA belongs into, is really a matter of one's perspective, or what lens that you bring to clinical care. So for me, and I think for Mike and for David as well, they run severe asthma clinics, and EGPA is a variant of severe asthma, where in a certain percentage of patients that we see with severe asthma in the clinic, some of those might actually end up being EGPA when we look for systemic manifestations, hypereosinophilia, in somebody who's referred to us for their refractory asthma. And then on the other end of the spectrum, for those of you in the audience who are rheumatologists, you look at EGPA through a very vasculitic world. If a patient comes to a vasculitis center with an ANCA-associated vasculitis and they're found to have high-grade eosinophilia, you look at EGPA as a variant of systemic vasculitis. And then for a select few of us, more of which are on this call for the IES, if you are an eosinophil specialist, as I also am in parts of my clinic, I think about EGPA as part of the differential for hypereosinophilic disease. So this EGPA is very fascinating in that way, and it lies in the nexus between severe asthma, eosinophilic disease, and systemic vasculitis. So to that point, as far as clinical manifestations, and do they inform us about whether you should best characterize EGPA as a severe asthma variant, an eosinophilic disease, or vasculitis? I think it's really all of those things at once. The French Vasculitis Study Group has published extensively on the disease characteristics of EGPA, which Mike will get into a little bit as well, or a lot bit as well. But I want to point out in this slide that only about a third of patients with EGPA are ANCA positive. So really only a third of the time are you truly calling a patient as having an ANCA-associated vasculitis definitively. And these ANCA positive patients are more likely to have renal, neurologic, and ENT manifestations. And from a mechanistic or disease origin perspective, EGPA is similarly complicated. It has multiple inputs leading to disease. And some of those are felt to be exposures, whether they be allergic exposures, infectious exposures, drug exposures. Some of those are genetic determinants. Data has shown that various MHC class II variants, specifically HLA-DR alleles, are associated with development of EGPA, but like anything, those are small associations. This is a polygenic disease with complex disease, genetics by environment interactions. IL-10 SNPs are also associated with EGPA development, and these in turn both influence and interact with dysregulated immunology, both on the eosinophil level, as the name of the disease implies, but also other components of inflammation, including abnormal T cell regulation, including dysregulated type 2 inflammation, abnormal Treg activity or decreased Treg activity. And also we're learning more that Th17 pathways are also important in EGPA pathogenesis. And then finally, the influence of humoral immunity as well, with B cells producing ANCA, which in and of themselves may be pathogenic. And then we see both at the tissue and blood level the presence of IgG4, which may also in and of itself be influencing the pathogenesis of EGPA. I don't need to go into this slide in great detail for this audience, but IL-5 is critically important for eosinophil biology, and therefore critically important for the pathogenesis of EGPA. And as David will get into, treatments that have become very critical for the management of EGPA target IL-5 or its receptor, and target not just eosinophil development from myeloid precursors, as you can see here in the lower left, but some of the other downstream eosinophil activities, including eosinophil survival, eosinophil migration, and eosinophil activation. Eosinophils themselves have cytotoxic granules. Again, this is very familiar to this audience. We talk about the effect of degranulation of eosinophils in multiple diseases, but in EGPA, is no exception. That tissue-mediated damage is likely mediated by the granules that are or the cationic proteins contained in eosinophil granules, which lead to asthmatic symptoms, which lead to airway remodeling in asthma. Also can cause vascular dysfunction, endothelial dysfunction, and potentially thrombosis, as well as neurotoxicity, and can actually feed into type 2 activation, which is a somewhat circular feed forward mechanism. And those eosinophils themselves don't necessarily need to cause vasculitis, but just the infiltration of eosinophils into organs can cause pathology. In this case, in this slide, you can see eosinophils that have infiltrated into the lung. So there are no actual vasculitic manifestations in this slide. It's just eosinophils in the alveoli. That in and of itself can lead to clinical manifestations here in the lung and here in the heart. Eosinophils between cardiac myocytes and infiltrating the heart muscle, which can lead to cardiac dysfunction. And then, yes, indeed, vasculitis can occur in some cases, and you may see that on pathology, though it's not necessary to see eosinophilic vasculitis on pathology. So I think this is an exciting time for not just for EGPA, but for eosinophilic diseases in general, that eosinophil depleting therapies have informed us about the role of eosinophils in disease and EGPA. We've come to learn that depletion of eosinophils does improve outcomes, and that tells us that eosinophils are essential for the pathology of EGPA. This paper that several people on the call participated in, but was led by Beth Jacobson in the Annual Review of Immunology, is a nice discussion about the implications of eosinophil depletion and what that teaches us about disease. Also, from a mechanistic perspective, I think we're learning more about the role of ANCA in vasculitis. That ANCA itself can lead to granulocyte, not dysfunction, but granulocyte activation and formation of extracellular traps from both neutrophils and eosinophils, leading to tissue damage. This is likely an important mechanism in EGPA as well. And some nice data from Manali Mukherjee and Param Nair go into that specifically in EGPA. I love this paper where Manali and Param took patients with EGPA who were both ANCA negative and ANCA positive in the serum, and found that there was actually sputum ANCA that was detectable even in some serum ANCA negative patients. So these patient A, patient B, and patient E are ANCA negative in the serum, but patient A and patient B in particular have detectable ANCA in the sputum. So there may be more than meets the eye here with the 1/3 ANCA positivity that we see in the serum, and that being a definitively different set of patients than ANCA negative patients. So there's a lot to talk about, but I'm going to cede the rest of my rest of the time to my co-speakers, and I'll end there and hand over back to the main slide deck, so I can now introduce my friend, Professor Michael Wechsler from National Jewish Health, as Matthieu told us at the top of the hour, where he leads the Cohen Family Asthma Center at National Jewish. He's a professor of medicine there as well. He has published prolifically in this space, including leading 2 seminal publications for EGPA treatment for phase 3 trials for mepolizumab and benralizumab. So we're lucky to have him talk to us about clinical manifestations of EGPA. Mike.
Hello, and I hope that you can see my screen. I just installed a new version of Zoom. So are you able to see my screen? Can someone just confirm that?
I can't. I'm just seeing the...
We can see it, Mike.
You can see it, Mark?
Well, I guess we see this picture of you.
Oh.
Your first slide.
Hold on a second. It was not letting me do it. It just hold on one second. This is my first time using the Zoom, so I apologize.
Mike, I think you stole that joke from me.
For some reason, it's not allowing me to share my screen, but I will try one more time. And there, how about now?
Yes,
Yeah.
you're good.
Okay, great. Well, konnichiwa to our Japanese colleagues, and it's great to participate in this webinar, really important topic, and thank you, Praveen, for that introduction. I'm going to review the clinical manifestations of EGPA as well as the impact of eosinophil depletion. And as Praveen said, this is a really exciting time to be a practicing eosinophilologist, as we now have some tools that can help us modify the inflammatory milieu and deplete eosinophils. These are some of my disclosures. Praveen gave an excellent overview of the EGPA disease pathophysiology. Clinically, one of the things that's become easily recognizable is that EGPA often evolves in a phasic developmental pattern. It usually starts off with an allergic diathesis that begins oftentimes with asthma or allergic rhinitis, and then progresses to a stage where there's peripheral blood eosinophilia or eosinophilic infiltration in various organs, but not necessarily with vasculitis. The third stage, or the terminal vasculitic stage, is when one first observes necrotizing vasculitis and granuloma formation. Now, all of these phases can overlap. They can occur in different order, different patterns. They can happen over weeks. They can happen over months, and they can happen over years. But most of the time, they just develop over the course of a few months. Now, EGPA is a disease that involves a variety of different organ systems, everything from the respiratory tract and the nervous system to the heart, the kidney, the GI tract, the blood vessels, and the skin. In the respiratory tract, it usually is manifest by asthma that's often severe and oftentimes adult onset. It's also often accompanied by pulmonary infiltrates that are generally either nodular, infiltrative, ground glass opacities. Occasionally, but rarely, that you might see alveolar hemorrhage. And then there's the upper airway manifestations, which is usually manifest as chronic sinusitis with or without nasal polyps. In the skin, this disease may present as palpable purpura, as seen in the bottom right hand, skin nodules seen in the upper left hand, urticaria, livido reticularis, and on biopsy, you may see perivascular lymphocytic infiltrates with eosinophils and thrombi. Other manifestations of EGPA include systemic manifestations. A large portion of patients present with fever, myalgias, and weight loss. Neuropathy is a very common presenting manifestation, as when patients present with neurologic manifestations, sensory or motor findings, they get concerned that they could be having a stroke, and they may present to a neurologist or an emergency room where an eosinophil count is identified as the culprit of the sensory motor issues that can sometimes also be central or just peripheral. Less commonly, the GI tract is manifest, and patients can present with abdominal pain, ischemic bowel, eosinophilic pancreatitis, or eosinophilic cholecystitis. The heart is involved in about 30 to 40% of patients and is often accompanied by a worse outcome. These patients can present with cardiomyopathy, eosinophilic myocarditis, congestive heart failure, or arrhythmias. Much less commonly is the presentation in the kidneys. Glomerulonephritis, renal insufficiency, or renal infarct occur in 10 to 25% of patients. In terms of the key laboratory findings, blood eosinophils are critical. If you don't have eosinophils in the blood or in the tissue, then it's unlikely that you have EGPA. If you have another entity and you're diagnosed with GPA, granulomatosis with polyangiitis, and you have eosinophils, it's likely that it's actually just EGPA. And I've seen eosinophil counts up to 80% of the total white blood cell count. But in general, we're looking for a level that's above 1,000 eosinophils. Usually, the eosinophils respond quite quickly to therapy. And I've asked members of the International Eosinophil Society, where do these eosinophils go? That could be a discussion point that we can review after this. Other laboratory findings include an increased sedimentation rate, elevated C-reactive protein, and a high IgE, rheumatoid factor, ANA, as well as IgG4. All of those are sometimes found in some patients with EGPA, but not all, but can give a clue to the diagnosis. In terms of anti-neutrophil cytoplasmic antibodies, we've already heard from Praveen that this occurs in 30 to 40% of all patients and may be seen in the serum or in the sputum of patients, as demonstrated in the study by Manali Mukherjee. Now on to EGPA management. EGPA, first of all, you need to make a diagnosis. You need to first distinguish EGPA from other vasculitides like GPA and MPA. And you also need to distinguish EGPA from other eosinophil-associated conditions, whether it's infections, which are the most common cause worldwide of eosinophilic diseases, malignancy, which is probably the most concerning, drug reactions, which are the most common cause of eosinophilia in the United States, a variety of other rheumatologic conditions, and then a few other eosinophilic syndromes, including chronic eosinophilic pneumonia, which is actually difficult to distinguish from EGPA because it too has asthma oftentimes, sinus disease, pulmonary infiltrates, as well as eosinophilia in the blood or in the bronchoalveolar lavage. Lastly, different hypereosinophilic syndromes can also mimic EGPA, but usually those patients do not have evidence of asthma or ANCA positivity or vasculitis. If they do, then it's probably an EGPA variant of one of the hypereosinophilic syndromes. In terms of EGPA management, the goals of EGPA management really fall into the both acute as well as the chronic management. In terms of acute management, at the time of diagnosis, one has to get the disease under control. And one of the key goals is to lower blood and tissue eosinophils, and then to prevent or minimize acute organ involvement. In terms of the maintenance management or the chronic management, the goal is to induce remission, to prevent relapses, and to prevent the long-term complication of induction therapies, and as well as the complications of corticosteroids, cataracts, glaucoma, osteoporosis, weight gain, hypertension, and many, many others. That being said, for the acute management of EGPA, usually we think of corticosteroids and more corticosteroids. Historically, this has been what's been utilized in the management of EGPA. And we generally start off with 1 to 2 milligrams per kilogram a day for several months. It's important to treat early on. And actually, steroids are effective in over 90% of patients in terms of the acute management of EGPA and quelling the disease. They often work by inhibiting eosinophil colony growth, inhibiting cytokine production, and inhibiting eosinophil survival. But the disease often recurs with corticosteroid withdrawal, and that's a problem. And very few patients historically have gotten off corticosteroids in the era before anti-IL-5 treatments. Lastly, not all patients respond to corticosteroids initially, and for those patients, we need other therapies, not to mention all the side effects of corticosteroids that I've already mentioned, including adrenal insufficiency and thinning of the skin and risk of infection. So which patients can get corticosteroids alone? Well, those with the least severe disease, those with a 5-factor score of 0 or 1, meaning they have no kidney involvement, GI involvement, cardiac involvement, or central nervous system involvement. The problem is when you use corticosteroids alone, relapses can occur at lower doses, so you need to taper very slowly. What does one do if steroids alone don't work? Well, then we need some type of add-on therapy. Or if patients relapse on lower doses of corticosteroids, generally the first step is to increase the corticosteroid dose to get the patient under control. Lastly, if steroids cannot be tapered, then one needs to consider step-down therapy. For severe acute disease, many recommendations recommend cyclophosphamide, which is a first-choice add-on therapy for patients with severe disease. They suppress the bone marrow. They may be helpful in terms of corticosteroid sparing. Both IV and oral formulations are effective, and it's been shown that 12 months is associated with fewer relapses compared with 6 months, but 6 months of treatment is associated with more side effects. And these side effects can be quite serious, including malignancy, sterility, and hemorrhagic cystitis that may limit their use in younger patients and in female patients. So what are the other options after corticosteroids and beyond cyclophosphamide? Historically, there have been many options: methotrexate, azathioprine, mycophenolate, rituximab have all been considered, and this was an era before anti-IL-5. The problem is that there are almost no trials and only case reports, only series and anecdotal evidence, and some of these data are based on other vasculitides or in asthma. With rituximab, we do have some good data in terms of its efficacy, in terms of B-cell depletion. Rituximab is an anti-CD20 that's been approved for both GPA and MPA, but there are only open label and uncontrolled trials in EGPA. One study showed as much as an 88% improvement at 12 months, with 49% of patients going into remission, but only 6% discontinuing prednisone. It improved a lot of the asthma and ENT manifestations, and it may be more effective in ANCA-positive patients. It also may be as effective as cyclophosphamide, but can also result in bronchospasm, allergic complications, as well as infectious complications due to the B-cell depletion. Azathioprine has also been considered, as it suppresses the bone marrow and lowers the eosinophils. It's been used in other vasculitides to transition from cyclophosphamide, but it too has adverse effects like neutropenia, GI, and hepatotoxicity. There's been one study which has looked at azathioprine in a variety of vasculitic conditions, EGPA, MPA, and polyarteritis nodosa, without poor prognosis factors. And what was interesting in this study, compared to placebo, there was no real demonstrative effect in terms of the probability of remaining relapse-free or in terms of the mean prednisone dose. In fact, addition of azathioprine to corticosteroids for patients with non-severe vasculitis had no significant benefit, no decrease in treatment failures, relapse rate, steroid dose, and there was also no improvement in asthma or sinus manifestations. Other alternative therapies, including interferon alpha, TNF blockade with etanercept, methotrexate, mycophenolate, and cyclosporin, have demonstrated some efficacy for the treatment of vasculitis. Some have been shown to be effective in asthma, but there is really limited published experience regarding the use of these in EGPA, and you need to weigh the potential benefits versus the risks. So what about targeting eosinophils? Well, we're in an era now where we've been able to target interleukin-5 as well as the interleukin-5 receptor. And it's been a very exciting time as we've given drugs like mepolizumab and benralizumab. Other potential targets are continuing to be evaluated, including those that target Siglec-8, the prostaglandin D2 receptor, the CRTH2 receptor, as well as the glucocorticoid receptor, amongst others. The first study, large study, that looked at the management of EGPA was a study that we did that was published in the New England Journal of Medicine 7 years ago now, in which we gave mepolizumab versus placebo to patients with relapsing or refractory EGPA. And in this study, it was demonstrated that mepolizumab increased the time to first relapse in patients with EGPA, with a significant increased time to first relapse that was longer for patients with mepolizumab compared to placebo. In addition, the rate of relapses was significantly reduced with mepolizumab, reducing the rate of exacerbations by 50%. Importantly, patients were also able to achieve remission with mepolizumab. When we look at the proportion of patients who were able to achieve remission, which was defined as a Birmingham vasculitis score of 0 and getting to a prednisone dose of 4 milligrams or less, you can see in this figure that a very large proportion, almost 40% of patients, were able to achieve remission with mepolizumab, compared to less than 10% of patients with placebo. Importantly as well, a large proportion of patients were able to taper their corticosteroids with mepolizumab. 57% of patients treated with mepolizumab achieved a greater than 50% reduction in daily oral corticosteroid dose, compared to only 21% in the placebo arm. The mean dose of prednisone in the placebo arm stayed at 11 milligrams a day, whereas those treated with mepolizumab reduced from 12 milligrams a day down to 5 milligrams a day by the end of the treatment period. We then evaluated other outcomes, and we looked at the efficacy in terms of this definition of remission, a BVAS score of 0, and or getting down to 4 milligrams or less of glucocorticoids. We also evaluated the probability of patients getting down to 50% dose of glucocorticoids or being relapse-free. If you look at any of one of these outcomes, 78% of patients with mepolizumab versus only 32% of patients with placebo were able to achieve one of these outcomes. If we use a less stringent definition of remission, getting down to a prednisone dose of less than 7.5 with a BVAS of 0, a 50% reduction in glucocorticoid dose, or being relapse-free, 87% of patients in this trial were able to achieve this outcome. Other outcomes that were observed with regard to remission, reduction in steroid dose, being relapse-free, or having any clinical benefit were observed independent of immunosuppressive use. They were observed independent of the duration of EGPA. They were observed independent of all sorts of a variety of other outcomes. When we look at the accrued duration of remission, patients who had a history of a positive ANCA or no ANCA, patients who had a BVAS of 0 or BVAS greater than 0, a VDI of less than 5 or greater than 5. There was a greater proportion of patients favoring mepolizumab who were able to achieve accrued duration of remission or remission at weeks 36 and 48. Mepolizumab also improved outcomes in both asthma relapses as well as vasculitis relapses. And this is a question that often comes up. Is it only helping the asthma and sinus disease? Well, what about other anti-IL-5 therapies? Mepolizumab is clearly effective. And we're delighted to publish this year this groundbreaking study comparing mepolizumab with benralizumab, the anti-IL-5 receptor antagonist, in the first head-to-head biologic study with any of these anti-IL-5 therapies. We compared benralizumab 30 milligrams a month to mepolizumab 300 milligrams a month. And it's important to recognize these are different dosing schedules than we're going to use in asthma, because in asthma, after the first 3 months, benralizumab is given every other month at 30 milligrams, and in asthma, mepolizumab is given at 100 milligrams a month. What we demonstrated was that benralizumab was non-inferior to mepolizumab with regard to remission, again defined as a Birmingham vasculitis score of 0 and getting down to 4 milligrams or less. It was as effective and non-inferior to mepolizumab, which is now considered still the standard of care. In terms of the primary endpoint in this study, compared to the prior MIRA study, what's interesting is that a larger proportion of patients were able to achieve remission in this study with benralizumab at 59% of patients or mepolizumab at 56% of patients. In the MIRA mepolizumab study, which was compared to placebo, only 32% of patients were able to achieve remission with mepolizumab. So we did much better in this study. A nominally significant greater proportion of patients receiving benralizumab achieved complete reduction of oral corticosteroids compared with mepolizumab. So that's another important outcome. Benralizumab patients, 86% of them were able to reduce their corticosteroid dose by 50% or more, compared to 74% with mepolizumab in this study. And 41% of benralizumab patients, compared to 26% of mepolizumab patients, were able to come off of corticosteroids completely. When we think back to the MIRA study, only 3% of patients on placebo were able to taper their corticosteroid down to 0. So this is a very significant, meaningful clinical effect for our patients with EGPA. Another interesting finding was the nominally significant difference in change in eosinophil count that was observed in patients treated with benralizumab versus mepolizumab. Patients treated with benralizumab almost got down to 0 eosinophils in the periphery. Some of the limitations of the anti-IL-5 data is that we don't have any significant data in acute disease. Most of the data is for relapsing or refractory disease. We also don't have significant long-term data, although we now have data out to 7 years with mepolizumab, 7.5 years. There's also still remains a bit of an uncertain role in the ANCA positive and non-eosinophilic vasculitic components of EGPA. I'm sure we'll discuss that in the discussion. And benralizumab has not yet been approved by the FDA for EGPA, although it is approved for asthma. And then there's other questions about other anti-IL-5 therapies. What's the role of reslizumab? What's the role of long-acting depemokimab at every 6-month preparation? What's the role of dexpramipexole? So in summary, EGPA is a complex syndrome. It's characterized by asthma, eosinophilia, sinus disease, pulmonary infiltrates, neuropathy, and vasculitis. The eosinophil is clearly central to EGPA pathophysiology, but it can be challenging to treat, so you need to treat aggressively. We have therapies that have been effective in terms of inducing remission. Steroids are still first line, but they can be associated with significant side effects. So we need to consider biologics and cytotoxic therapy in steroid refractory disease as step-down therapy and for relapses. And it's clear to me that anti-IL-5 therapy with either mepolizumab or benralizumab leads to remission in EGPA and facilitates corticosteroid withdrawal. So thank you so much for participating. I'll let our next speaker, Professor David Jackson, continue. I'll let Praveen as well introduce him.
Great. Thanks, Mike, for the incredible talk. Looking forward to some more discussion about that during the Q&A section. And with that, it's my pleasure to introduce our next speaker, my friend, Dr. David Jackson, who is a professor of respiratory medicine at King's College in London. He also is the head of the Severe Asthma and Eosinophilic Lung Disease Service at Guy's Hospital in London. He's similarly prolific in this space, both in eosinophilic disease and eosinophilic asthma and severe asthma. He's led real-world evidence studies of IL-5 receptor monoclonal antibody therapy in EGPA, and he will tell us a little bit about the multidisciplinary approach to EGPA and future directions as well. So with that, I will hand it over to you, David.
Thanks, Praveen. Good morning, afternoon, wherever you are. Thanks very much to the International Eosinophil Society for the invitation to speak to you. And I've been asked to speak on two, I guess, different aspects of EGPA care. First is about the multidisciplinary approach. And the second is about future directions in EGPA. Firstly, these are my disclosures, which I probably don't think are going to be relevant for this specific talk. Now, the idea of the heterogeneity of EGPA has already been introduced to you all. It's not very hard to understand why you would need a multidisciplinary team approach to care when you look at the varying manifestations that can present in your patients with EGPA. But what I'm going to focus on actually is the notion that depending on the setup you have and whether you are based in an asthma respiratory service or more rheumatology or more renal, you will naturally see a slightly different cohort of patients that will require a slightly different multidisciplinary team makeup. And I'm just showing you our cohort because this is the data that we published from our cohort, 2 years of data with benralizumab, 70 patients, but just to show you the range of comorbidities or sort of organ involvement that is much more typical of the MIRA and Mandara studies, but actually quite different from some of the rheumatology-based services. But if we look at my co-authors from our center, this is single center work. It is a group of pulmonologists, rheumatologists, ENT, cardiologists, and surrounding us are specialist nurses and pharmacists, all of whom are critical members of the team who support our patients with EGPA. When you think about mortality in EGPA, one of the key things has always been cardiac involvement. And it's very important, in my view, to have a cardiologist who you have good communication with, who is part of the team, because there are many different manifestations of cardiac EGPA, as shown here. This was just recently published by my colleague, Tevfik Ismail, who's the cardiologist who sits in our clinic with us. When we see patients, there is a respiratory physician like myself or one of my colleagues in our service, and Tevfik is the cardiologist, and we have a rheumatologist as well. And we see patients together because we each clearly have strengths in different aspects of care. And in this respect, if we think about the kind of distribution, the spectrum of disease manifestations, rheumatologists naturally have more experience with using therapies that target vasculitis and vasculitis-related inflammatory pathways. Myself, as an asthma physician, has more experience than rheumatologists in using anti-T2 and asthma biologics that we target, that we use in severe asthma. But apart from the simple disease manifestations of EGPA, we have the reality is that the multidisciplinary approach must also, as Mike highlighted, focus on protecting our patients from harm from steroids. Now, steroids appear all over the treatment pathway in EGPA, as you can see here, both in terms of new onset EGPA, relapsing EGPA, whether it's severe, non-severe. And just to put this into perspective, if we think about going back to our cohort, the level of steroid exposure, the average dose of patients when we started benralizumab in our cohort was 13 milligrams per day of prednisolone. Now, over a year, that is about 5 grams per year. And many of these patients have been on prednisolone for several years. And if we look at data like this, which shows the risk of cumulative of side effects of steroids based on cumulative exposure, this is in almost 500,000 patients with asthma from the UK. And we're looking at the hazard ratio of asthma compared to patients with asthma not on systemic steroids. We see that 5 grams already puts you in this penultimate column where you're having an almost 3-fold increased risk of osteoporosis and fractures, almost a 7-fold increased risk of depression, anxiety, almost a 13-fold increased risk of pneumonia. You have a patient who's been on that level for 2 years, and that goes up further. So thinking about a multidisciplinary care within EGPA, it is not simply having a respiratory physician and renal physician, rheumatologist, and so on, but it is actually about managing the manifestations of the steroids and the steroid-related consequences. So here it's important to involve endocrinologists from the point of view of osteoporosis, adrenal insufficiency, diabetes management, encouraging patients to get eye checks. Many patients unfortunately develop glaucoma or cataracts as a consequence of steroids. We have a clinical psychologist in our service, both to support patients who have to deal with a potentially life-threatening chronic illness, but also because of the psychological side effects of systemic steroids themselves. And of course, a cardiologist will help support hypertension management, lipid management, which I'm embarrassed to say is often poorly done in his absence in my clinic. As I said earlier on, the pharmacist has a critical role within the MDT management of patients with EGPA, discussions around side effects, support with adherence of therapies, drug monitoring, all really important roles. And the nurse as well, who is there as a specialist nurse, who's an advocate for the patient, who links all these different members of the MDT, who is the patient's representative at the MDT, is so critical as well. The second part of what I've been asked to speak about is future directions. And I'm actually going to start by mentioning guidelines, which does not at first glance appear like a future direction, but I've underlined evidence based on purpose. And Mike, in his talk just before me, alluded to this. And so linking to this, I'm going to just mention about using the anti-IL-5 receptor therapies at remission induction, which is also something that we are needing to move to. And coming back to these guidelines, which I showed you earlier, mepolizumab, and I've added benralizumab here too, is basically placed in 3 positions. Virtually every other drug on this slide has no real evidence base in EGPA in terms of controlled clinical trials. By far the best evidence base is mepolizumab and benralizumab. Yet it is not mentioned everywhere. There are words like or placed at different positions, which seems ridiculous given that this is the only evidence-based treatment in EGPA, and it is the one with the least side effects. Other treatments, methotrexate, azathioprine, which Mike highlighted before, have really no evidence base, no evidence to support their efficacy in controlled studies where EGPA patients have been included. And given the risks of systemic steroids, as I just highlighted before, the notion that, for example, at the bottom over here on the right, it says for relapsing EGPA, even if it's not severe, that you would use steroids alone, when we know these therapies are steroid sparing, when we know these steroids are associated with such significant side effects, to me seems a bit ridiculous. Unfortunately, this is the current guidelines. So the future direction must involve a rapid move away from this. At the same time, the notion of using these drugs earlier. In my mind, there is no rationale for why you wouldn't start the steroid-sparing mepolizumab or benralizumab as soon as possible once a patient has uncontrolled EGPA, even if it isn't that initial remission induction. If your goal is to induce remission, which by definition involves weaning off prednisolone, then you are going to need a drug which has steroid-sparing efficacy, and the only drugs proven to do that are mepolizumab and benralizumab. The second aspect is, of course, combination treatment. Now, this is already actually highlighted within the guideline here, where it says, for example, steroids plus rituximab and mepolizumab, but there is no evidence base for it. And I would go further down here and with relapsing EGPA to again think about the notion of using a drug like rituximab with benralizumab rather than either alone. Mike showed data for mepo and benra. This is on the left, data from our center. But what it fundamentally highlights, and we looked over 2 years of benralizumab therapy, and we saw remission in 2/3 of patients overall with benralizumab. When you depleted eosinophils, you achieved remission in 2/3 of patients. But there are some patients, despite being ANCA negative, despite having an eosinophilic, strongly eosinophilic phenotype, who don't achieve that remission. But we did not see differences between ANCA positive and ANCA negative patients, although ANCA positive patients are always in very small numbers in all of these studies, making the ability to power this difference difficult. But on the other hand, there are drugs like rituximab. Rituximab is an anti-CD20 monoclonal antibody that targets B cells that do have a better evidence base, certainly in other ANCA-associated vasculitides. And the notion that these therapies would be better in the ANCA-positive patients has some degree of support. And I'm showing you data here on the right, showing the relapse-free probability, and this is in the subgroup of asthma and ENT relapses, showing better response in the ANCA-positive patients, which is the green line here on the right. So the notion that you would combine these two makes perfect sense. There will be some patients where you both need to target the eosinophilic component and the non-eosinophilic vasculitic component. What is critically important and a real unmet need is to properly phenotype, endotype relapses in patients on mepolizumab or benralizumab to really understand what are the residual therapeutic targets that need to be addressed. There is a temptation to assume that if you relapse on mepolizumab or benralizumab, that it is a non-T2 driven relapse. And I'm just going to show you 2 clinical cases to make it clear that this is not the case. This is a patient of mine who has ANCA negative EGPA. Severe asthma, was initially presented with an eosinophil count of 10. So depending on which units you use, this is 10,000 cells per microliter back in 2017. Marked eosinophilic infiltration on skin biopsy, commenced on mepolizumab at the asthma dose back in 2017. We didn't have access to the EGPA dose, and the patient did very well despite the asthma dose, went into remission for 6 years, then relapsed in November, just over 6 months ago, with respiratory, skin, and general fatigue, and we switched to benralizumab subsequently. But what I'm showing you is a screenshot of this patient's bloods. Now, we are in a very fortunate position at Guy's where we actually can measure IL-5 and IL-13 in serum routinely. What I'm showing you here is the blood eosinophil counts in the top row when the patient was in remission on mepolizumab. You can see very low numbers, 60 cells, 70 cells, 90 cells per microliter across 2021 and 2022. Then this patient had this relapse on mepolizumab in about 6 months ago, December 2023, when the eosinophil count suddenly goes to 420. And then it comes back down to 0 once they're switched to benralizumab. But what you can see is the IL-5 levels that have gone from 27 picograms per mil to 320 picograms per mil. Patient was ANCA negative, and you can see the IgE rise as well. So this is a patient who is on mepolizumab, who has a relapse, but it is clearly a relapse associated with a surge in eosinophils, IL-5, IgE, and so on. This is a second case. This patient, severe asthma, was transformed to EGPA, which was ANCA positive in February 2022. The eosinophil count was 8,700, had anti-MPO titers of 82, presented with hemoptysis, lung infiltrates, initially treated with cyclophosphamide, started on benralizumab at the asthma dose in August 2022, so coming up to 2 years ago. Did very well, was able to wean their maintenance prednisolone from the dose of 20 milligrams a day that they were stuck on down to 7.5 milligrams per day over 6 months, and then relapsed in May 2023. And again, I've screenshotted the bloods again. This patient's on benralizumab, so does not have any eosinophils at all from the blood. You can see levels of 0 throughout, including during the relapse. But the IL-5 levels surges during that relapse. You can see this is May 2023, goes from 74 to 480. It's interesting because in March, 2 months earlier, there was already a rise in the IL-5 and a move in the anti-MPO from 0.5 to 1.5, which is still normal range. But then, 2 months later, the MPO was now back up at 21. The IgE had risen from 190 to 3,000 during this relapse. The point I'm showing you here and making is the notion that just because this patient's having a relapse on benralizumab and you don't see any eosinophils because you've lost the eosinophil signal, does not mean this is not a T2 IL-5 associated inflammatory episode. Lastly, new treatments. Now, I've been given 20 minutes to do all of this, so I'm just going to touch on this. And I've chosen to really touch on one of the most interesting findings of the GWAS in EGPA, which was the identification of TSLP as a potentially relevant loci of interest here. Now, TSLP, as I'm sure most of you know, is an epithelial-derived alarmin. It induces the maturation of dendritic cells, and this leads to the upregulation of co-stimulatory molecules, which are really important for the polarization of T cells to a T2 phenotype, macrophages to an M2 phenotype, lymphopoiesis, and ILC2 activation. And as you can see on this figure here, if you just look at the ILC2 for a moment, the data highlights very clearly that TSLP ligation increases the expression of the IL-33 receptor, the IL-25 receptor, and the ILC2 is one of the main cells that have been associated with EGPA activation and so on. So there's very good rationale, both from a GWAS and from what's otherwise known from the inflammatory cascade in terms of T2 biology, to suggest TSLP would be a good target. Now, this is data from asthma, the main phase 3 asthma study, showing the impact of tezepelumab on the blood eosinophil count on the left, FeNO, the fractional exhaled nitric oxide, which reflects IL-13 levels in the airway, and total IgE on the right, which of course reflects IL-4 B cells. And you can see a very rapid reduction in the blood eosinophil count and FeNO. The units here are changed from baseline. But I also just want to show you this. Now, this is unpublished from our center. And I'm showing you this because it's relevant potentially for how we think about the use of tezepelumab in EGPA. On the left here, this is 100 patients from our center with severe asthma. This is not EGPA, who were treated with tezepelumab. And I'm showing you the impact on the T2 biomarkers of tezepelumab. In red is everyone, the 100 patients. Then the dark blue are patients who have switched from an anti-IL-5 or 5 receptor therapy, and the light blue are those patients who are in biologic naive. And on the left, I'm showing you the eosinophil count. And what you can see here is a rise from baseline to 6 months in terms of the eosinophil count on Tezi, because of the baseline level still had the residual effect of largely benralizumab, some epolizumab patients. You don't see this with FeNO, but you see that with the eosinophil count. And when we look at our data, what we see is, if we look at the proportion of patients who still have, relatively elevated levels of these biomarkers at 6 months, once established on tezepelumab, we see 23%, almost quarter of patients, still have an eosinophil count of 300 or more, despite tezepelumab. So there is a very real question that, even though it may seem like a good target, the question of whether there is sufficient eosinophil suppression with anti-TSRP in patients with EGPA is relevant at the asthma dose. And the other doses, of course, haven't been tried in this way. But what tezepelumab has shown to be very, very useful for in our clinic and others is on the sinonasal symptoms. And many of you who look after EGPA patients will know that whilst their respiratory symptoms and many other aspects of their disease will remain well controlled, the sinonasal disease does not. Now, this is data which was presented at Quad AI, not in EGPA, in patients with Samter's triad, aspirin-exacerbated respiratory disease. These are patients who have severe asthma with nasal polyposis and aspirin sensitivity. And we're looking here at the SNOT-22 questionnaire results. So the improvement in sinonasal symptoms, which is very marked, 24 at 28 weeks, 29 compared to placebo at 52 weeks is a highly significant improvement. And if I just show you a single patient of mine who was switched from benralizumab to tezepelumab, you can see the difference on the imaging. So on the top row here, this is a patient who had already been established on benralizumab for 18 months and still had very significant sinonasal inflammation, as you can see. We switched this patient to tezepelumab. There was no change in steroid exposure. This patient was not on maintenance prednisolone, did not change their nasal steroid dose. This is simply the impact of changing from benralizumab to tezepelumab on sinonasal inflammation. You can see here the sinuses are significantly clearer. These are identical slices. So it is exciting from the point of view of improved sinonasal control in terms of EGPA. The one other treatment I just want to mention is avacopan, because there's a lot of excitement around avacopan in terms of ANCA-associated vasculitis disease more broadly. So ANCA-induced neutrophil activation drives alternative complement pathway activation, leading to C5a production. And C5a production has been shown to be an important component in the pathogenesis of ANCA-associated vasculitis. Patients with both MPO and PR3 ANCA-associated vasculitis have increased plasma levels of complement activation products like C5a, and patients in remission, those levels go down compared to patients with active disease. Avacopan itself is an oral small molecule C5a receptor antagonist, and it blocks neutrophil chemoattraction and activation. And in a murine model of ANCA-associated vasculitis, avacopan prevented the development of glomerulonephritis induced by anti-MPO antibodies. And you can see the data on the right from this study, essentially showing better outcomes compared to prednisolone. Unfortunately, there were no EGPA patients in this study. As with virtually all the ANCA-associated vasculitis studies, they are virtually all about 60% GPA with the remainder MPO. So the MPA. So there's no data currently in EGPA, but it's not completely unreasonable to assume that in some of the ANCA-positive patients who have a very vasculitic phenotype, that this may be a potentially useful treatment. So just to summarize EGPA is a complex, heterogeneous disease which requires a multidisciplinary team in order to provide optimal patient care. Hopefully, I've made that point today. Current treatment guidelines are, in my view, suboptimal due to extrapolation all too often from other ANCA-associated vasculitides. The fact is that the anti-IL-5 5 receptor therapies, mepolizumab and benralizumab, have by far the best evidence base in EGPA, and in my view should be started in all patients who are reliant on systemic steroids as quickly as possible. There's no doubt that improved endotyping in stable state and during disease flares is needed to inform a more personalized approach to the use of non-IL-5 5 receptor therapies such as rituximab and avacopan. Broad-acting anti-TSU therapies, basically a safer version of systemic steroids, like anti-TSLP, do without question have potential, but we just need to bear in mind whether the eosinophil suppression may be sufficient in some of these patients. And what I haven't touched on, but obviously given the importance of the ILC2 that's been shown by many investigators, the efficacy of anti-IL-33, which is out there but not been shown in EGPA yet, certainly needs to be evaluated. So I will stop there. This is my fantastic team at Guy's who all contribute to the care of our patients with EGPA. Thanks very much.
Thanks, Professor Jackson, and thanks to all three speakers for these excellent talks. We have a lot of questions in the Q&A. We're going to go through them now, and then we'll, if we have time, we'll try to extend the discussion to perhaps the future directions on using eosinophil depleting agents and other autoimmune disease besides EGPA. Just to start with, there's a question from Mark Rothenberg for any of the speakers. Given the heterogeneity of EGPA between patients, but also in terms of different organs in the same patients with or without vasculitis, how can Mark is struck with the apparent broad benefit of anti-eosinophil therapy. And so can this be explained? And are there components of EGPA that are not touched by anti-eosinophil therapy? Long question.
Yeah, I think the broad efficacy of the anti-IL-5 eosinophil depleting therapies that's seen in patients with EGPA highlights the important role of the eosinophil in EGPA. That it affects a variety of different organ systems. The eosinophils infiltrate many different systems. And that's why we're seeing the broad efficacy. I think the shortcomings of anti-IL-5 therapies in patients with EGPA may relate to patients who already have damage as opposed to active inflammation, and or if there are other potential mechanisms of disease, more neutrophilic component, or perhaps the ANCA-mediated component. I'll let my colleagues answer as well.
David, do you want to jump in since this kind of dovetails with your talk?
Yeah, no, I mean, it's a good question. I mean, the fact is that the eosinophil appears to be related to both the vasculitic and non-vasculitic components of EGPA, actually. It drives, thrombus formation, and there's lots of different mediators that are released by the eosinophil that kind of link both the vasculitic and non-vasculitic components of EGPA. So on the one hand, I'm not surprised that MEPO and BENRA both work across the spectrum in that sense. I think it's interesting if we think about the other T2 diseases and we think about nasal polyps, for example. Mepolizumab and benralizumab has generally been disappointing in nasal polyposis, but dupilumab has been very effective, suggesting more IL-13 is important. We know from EOE, that's certainly the case. There is this, differential response where other elements of T2 inflammation are more important. So as sort of I alluded to, it's not completely clear at the moment how much of the IL-5 5 receptor non-responders are not responding because of non-T2 issues, pathways relating to ANCA itself, or actually just other parts of T2 inflammation.
Or adrenal insufficiency.
Yeah.
Yeah, I mean, I do agree with Mark that it's remarkable how, how broad-based the effect of anti-IL-5 therapy is, but it's not complete, David, as you showed in particularly in your second case in your talk. Also, I agree with you, David, that it's kind of ridiculous. Well, and we understand why that is from a guidelines perspective because we haven't generated the evidence yet, but it is kind of on face value ridiculous that we don't give anti-IL-5 therapies for induction of therapy in life-threatening disease. But that said, my guess is that eosinophil depleting therapies would not be enough in those cases. People who come in super hot with rip-roaring vasculitis. Apologies for the idiom for the Japanese translators, but people who come in with very active vasculitis, just depleting eosinophils is likely not going to be sufficient for those patients. It does indicate that there are other mechanisms at play, underlying disease. I think we do know that there's dysregulated alternative T cell subsets, Th17 cells that are dysregulated. So yeah, and as Mike said, the neutrophil component I think can't be ignored either. So yeah, I think it's yes, I agree with Mark, but there are some I think cases where it's clear that there's more than just the eosinophil here.
I do think it's a good opportunity to also mention that not being able to start the anti-IL-5s early on because of access issues could be an issue as well. Oftentimes it takes weeks to get approval of some of these therapies. And if we could work with both the pharma companies and payers to make these therapies more accessible in the acute phase, I think would be a huge benefit for the acute management of EGPA. And we could generate some data in that cohort as well.
Great. I think I'm going to ask this next question because you might have an answer to it that you had put in our panelist chat before. Maybe we'll do this question from Dr. Aditya from Chennai, who asked about the type of neuropathy pattern in EGPA. Whether you see more mononeuritis, multiplex, or polyneuropathy.
You can see both, and I've seen both. More often than not, I see polyneuropathy as opposed to mononeuropathy.
Yeah, I would agree. Usually it's hands and arms and feet. Sensory abnormality, but sometimes it can be CNS, it can be other mononeuritis, but usually I've seen it's poly.
Just to add a word on that, on the neurologic manifestations, there is an excellent Japanese paper a couple of years ago published in Neurology where they compared the histological characteristics of the patients where they're ANCA positive, ANCA negative. So it's not black and white, but there is much more mononeuritis, multiplex presentation, and vasculitis features in the ANCA positive patients, obviously, and in the ANCA negative. Surprisingly, it's more like subacute presentations, polyneuropathy, and the major histological finding is thrombosis in the vessels from the epineurial wall. So it's probably not the same pathophysiology, and possibly you want to treat these patients differently depending on the clinical presentations. And on the CNS presentation, it's different. It's mostly strokes with watershed distribution, which is mostly specific to eosinophils. There are multiple questions. I think we need to move along. There's a question for Professor Wechsler regarding data from the Mandaris study and the benefits regarding the steroid-sparing effects of benralizumab. Could you, from these data, can you conclude that benralizumab is superior to mepolizumab regarding steroid effect or not?
There was a nominal difference in terms of the proportion of patients with benralizumab were able to taper off of corticosteroids with benralizumab compared to mepolizumab. I'm hesitant to say that there's definitive superiority in that regard. I don't know what my colleagues say. The study wasn't designed to evaluate that specifically, but it certainly, the numbers certainly did favor benralizumab in that regard. David, Praveen, what do you think?
Yeah, I think it's suggestive. I think it's not definitive proof. You know, you want to believe it because it kind of makes sense at face value, you know, with potential greater eosinophil depletion. But I think we need to generate probably more evidence designed around answering that specific question. What's the nature of science? So agreed, Mike.
Yeah, no, I mean, I think that's right. I think the likelihood is that there, for some patients, the eosinophil reduction with mepolizumab won't be sufficient, and you would get additional benefit, and that's not a huge stretch to think that. And certainly we see it with asthma when we've switched patients who, particularly eosinophilic, particularly severe patients, from the asthma dosing of mepolizumab to benralizumab. We've seen improved outcomes, but you know, this was set up as a non-inferiority study.
There's an interesting question, it's more provocative thought, is given the evidence or the lack of evidence, should we still use DMARDs, MMF, azathioprine, methotrexate in EGPA? It's in the recommendations, but
yeah,
do you experts still use it in daily practice?
I think it really is going to depend on the patient and the other manifestations that the patient has, and at what stage. But for remission induction, and in patients who have relapsing or refractory disease, I would go with an anti-IL-5 first. I don't think it's unreasonable to consider some of the other options for some of the manifestations that might be more responsive to those therapies, particularly if they have more arthritic complaints. Again, this hasn't been looked at. There have been no head-to-head studies. The patients that were included in both the MIRA study as well as the Mandara study, there was a subset of those patients who were already on those therapies who had yet to achieve remission. And so the suggestion is that add-on therapy with either MEPO or Benra is an effective add-on therapy. Is there a role? There might be for some of the manifestations. I try to minimize my polypharmacy with patients, and I would go with a first-line anti-IL-5 therapy to start with. And if they continue to have other arthritic manifestations or other manifestations that might be potentially be responsive, I'd consider them.
Yeah, and I think, you know, the point really here is the idea that you shouldn't delay starting, if you have access to mepolizumab or benralizumab, you shouldn't delay starting that whilst waiting for azathioprine methotrexate to work, given the evidence base of mepo-benra versus the evidence base for azathioprine and methotrexate, and given what that means in terms of cumulative steroid exposure as a consequence of that decision. And I think that's the key thing in terms of preventing avoidable harm from steroids for your patients. It's not appropriate based on the current evidence to start somebody on azathioprine or methotrexate or MMF instead of mepolizumab or benralizumab if you have the access to those drugs.
I 100% agree.
Should we take a minute to talk about the discussion topic that was on the agenda, just to do that maybe as a single question and see what people's thoughts are to that?
Sure.
Which I believe that discussion topic was, is there a role for eosinophils in other autoimmune diseases beside EGPA, and for eosinophil depletion in those conditions? Maybe a little bit of food for thought.
I think if there isn't evidence of substantive eosinophilia, then I don't think there's a significant role of using an anti-IL-5 therapy. But there are other conditions in which the eosinophils do play a role. I listed a short differential diagnosis of other eosinophilic conditions. And we know that in some diseases like inflammatory bowel disease, there can be eosinophils. In sarcoidosis, there can be eosinophils. So I think for those types of conditions, it might be appropriate. But if there is no evidence of eosinophilia, I don't see why one would use an anti-IL-5 therapy.
I think, I think what we've learned from many other diseases now, and we didn't know this until we started using drugs like mepolizumab and benralizumab, that sometimes the eosinophil is a marker of a process, but it's not the appropriate target. And I think Mark, obviously, who's the leader in this for EOE, it was demonstrated very clearly there that just because you see eosinophils in histology doesn't mean it's the appropriate target. With the negative study with EOE with benralizumab, we've seen nasal polyposis, as I've mentioned, disappointing results with mepolizumab and benralizumab. So even though those nasal polyps are very eosinophil rich when you biopsy them. So I think there are many other conditions where you may see eosinophils, but actually depleting them may not solve the underlying problem.
I fully agree. Perhaps just also worth mentioning IgG4 related disease, where a substantial percentage of patients, roughly a third, have evidence of type 2 inflammation. So you might want to consider type 2 targeting biologics for the nasal polyposis or the asthma, but for sure it's not gonna. It's the same as for the EGP and the vasculitis component. It's not gonna make disappear the fibro-inflammatory infiltrate, but it's going to improve the type 2 symptoms.
Yeah, agreed. So there's one question here that maybe I'll jump in and ask. Are there any surface, and this is from Dr. Yamada, are there any differences in the surface molecule expressions and cytokine production of eosinophils themselves between EGPA and those in other other diseases, such as allergic diseases? So very an eosinophil, phenotype specific question.
I haven't seen data yet, but it's a really important question and one that I think many of us are interested in answering. I'm sure many people have seen Jeff Chupp's paper looking at eosinophils by Saitoff from the Muppet study, mepolizumab in kids. And if you haven't seen it, it's definitely worth a read, because basically what it highlights is differences in eosinophil phenotype between those patients on mepolizumab who continued to exacerbate and those that didn't. And of course, these were all from sputum. And that's different from Claire Mesnel's original paper, which was sputum in asthmatics compared to airway, biopsy specimens in non-asthmatics, and comparing eosinophils there and suggesting there's two different phenotypes, when actually it's just the expression of the eosinophil in that very, very different cytokine milieu which is surrounds it. And so I think it's very possible, and we need to answer this, whether patients with EGPA who do respond to anti-IL-5 therapies actually do have a different kind of expression than those that don't. Whether number one, and whether eosinophils in patients with EGPA are different from patients with eosinophils in patients with severe asthma. Again, so that work definitely needs to be done, and we now have the techniques to be able to do that with Saitoff and so on. So hopefully someone will do it soon.
Yeah, and this is something that I've given a lot of thought to, that Mike and I have had conversations about, have tried to get funding to try to answer these questions. It's logistically complex because eosinophils can't be cryopreserved. You have to have eosinophils that are present in a patient who is active and has detectable eosinophils, perhaps even off therapy, which is difficult as well in this disease. Patients who are on systemic corticosteroids, it's difficult to recover eosinophils. Is blood eosinophil a appropriate compartment to study versus airway versus tissue? So that adds to the complexity of doing these studies. But I do think it's, as you said, David, it's possible. It just needs to put a lot of complex pieces together to answer these questions. And I think with the Muppet study, they had the benefit of the placebo arm as well, and some residual eosinophils in non-responders as well, which those kind of things can be taken advantage of in EGPA. But for kind of really understanding eosinophil differences, I think trying to find these patients who are, fresh, new diagnoses, who have, that patient that you all of a sudden are surprised to see an eosinophil count of 6,000 on the CBC, to get those eosinophils, to get airway specimens, induced sputum from those patients, perhaps nasal brushes. That's going to be, how we tackle this question.
By the way, I'm starting to type answers to some of the questions that have been put online, and I encourage David and Praveen as well to do that. I have one question for Matthieu. You put in a private text that there's some data with rituximab in EGPA that are going to be emerging soon. Can you comment on that?
Yeah, sure. So the French vasculitis study group has led 2 trials. One at the with rituximab versus standard of care for remission induction, and then another trial for the maintenance of remission. The first part, which is the REOVAS trial, was shown at the latest American College of Rheumatology Congress, and it's a negative trial. So there's no benefit of rituximab. It's another negative trial with immunosuppressants in EGPA at the acute phase. And what I can say, so the paper should be released soon. It's a negative trial, but when you extend follow-up, there is a benefit for the subgroup of patients that are MPO positive. So maybe we should think about getting towards personalized therapy, use the immunosuppressants of the rituximab for the MPO positive, and then the patients that are ANCA negative mostly use the type 2 targeting agents. That's the key message of the trial.
So we're over time, but maybe we'll answer one more question if people can stick around, and then if there's any outstanding questions for us, you can email the IES at info@eosinophilsociety.org, which was just put into the chat to everybody. So you can email us for outstanding questions. There's many incredible questions still in the Q&A. But does anybody have a favorite on here that they've seen? I think Imran Satya asked, why does ANCA anti-neutrophil cytoplasmic antibody why is it associated with a hyper-eosinophilic disease like EGPA, which I think is an interesting question. So maybe we'll end with that one.
It's a long one, that one. The truth is we don't know exactly how ANCA, it induces neutrophil activation, and that obviously drives the complement activations we've said, and C5a, and it sort of creates this positive feedback loop. How that all links to eosinophils, it's not completely clear, other than obviously you have plasma cells producing ANCA, you have plasma cells producing IgE, and the source for those plasma cells, the drivers include IL-4, and so you just have to kind of go back up the pathway to have common cells that drive both eosinophilic inflammation, like the ILC2s and IL-5 and so on, and also ANCA production. So there was this dysregulation between the innate and the adaptive pathways within EGPA. We don't fully understand in reality on the background of this genetic predisposition. It's a hard one to explain. I need a picture.
Yeah, I think my one addition to that is that the ANCAs that are detected may be in a spectrum of autoimmune antibodies that may be present and not yet characterized. That anti-myeloperoxidase antibody may there's good reason to think that they would potentially react with eosinophils as well. So what we call ANCA may actually be AECA. We're detecting something that in non-eosinophilic disease does indeed react primarily with neutrophils, but has cross-granular side effects. So that would be my one other alternative explanation.
Nothing else to add.
Okay, well, should we?
I'm still typing answers to questions here. I'm happy to stay on to finish.
Okay, well, we'll conclude the webinar there as Mike is furiously typing. Thanks to Dr. Groh, Professor Groh, my co-moderator, to Professor Jackson, Professor Wechsler for incredible presentations and for the really, really good questions. This was a great session. Thanks, everyone.
Thank you, everybody.
Thank you.